where I just see patients who aren't able to get resources in, where I see it really affects their health. So I think that led me to some of the work I'm doing now. And I'll share with you, at least briefly, some of the work that we've been doing now in my kind of research group. Um, so I'll talk about testing social prescribing for loneliness in the Seattle context and talk a bit about kind of what led me to do some of the work I'm doing now and also how we're approaching it in the Seattle context of the University of Washington. Um, so just disclosures, I have some funding from a few foundations and from NIH as well, but otherwise I have no other conflicts or commercial interests. Um, we have an interesting social prescribing model because I think we decided to do a group-based model because of several things that emerged. I think I'll talk a bit about our local context and then some of the challenges with current evidence that we have around social prescribing. I think what we know about social prescribing is that, like, anecdotally, patients really love it, right? Like, I think providers have stories that it works, but that has not, unfortunately, been seen in the studies. And I think it's because my guess is it's because a lot of people are super excited about it and so excited about it that they're doing it, but no one is running like the gold standard RCT, like randomized controlled trial around it. Um, and we see this in the I think in the Europe context and the UK context, and I think some of it here as well, where we're so excited to implement this that there isn't the randomized control trial behind some of the work we're doing. So kind of as a clinician scientist, I'm hoping to bridge some of that gap. And what I'm hearing from reviewers and scientific experts is like, why are you even testing this? Because there isn't evidence that you should be testing it. I'm like, well, people are doing it already, so we should be testing it. So it's like this gap between like what the funders are looking for and what's happening on the ground in reality. And I think what's happening, what we're all excited about. And then I think the other context that I want to share about what we're doing is specific to the Seattle context. So this is not today, but like because it's pouring rain and windy outside right now. But this is like I think what I thought about as Seattle when I first joined, and I just want to dive into some of the context of how we got to some of the specific populations we looked at. Because I'm a family doctor, I wanted to just treat everyone broadly, but there is no research funding for just primary care research, right? Easily accessible. So I had to look at specific populations and high risk populations. So the first population we looked at were young adults, tech workers. We found that a lot of them on survey and in my clinical experience were really lonely and isolated, especially at the beginning of the pandemic. This is, for those of you who are not familiar, the Amazon headquarters in Seattle and their kind of signature biospheres in our downtown Seattle area. And a lot of people, before they headed back to the office mandate, came to my office as patients, just like expressing a lot of loneliness and social isolation. And also a lot of social anxiety as well, not being sure how to talk to people, and being kind of afraid and anxious about approaching other people. So that was one group that I really wanted to address. A few blocks away from the Amazon headquarters, unfortunately, we do have a lot of people who are unhoused, empty storefronts in certain areas, and also a lot of substance use disorder that we were looking at in Seattle as well. So I also was able to focus another pilot with people who had substance use disorder or were at risk for substance use disorder as well. And then finally, I think from some of our pilot work, we realized that people who are sexual and gender minorities were really at high risk as well. And in Seattle, like about 15 and 20% of people when surveyed identify on the LGBTQIA spectrum. So I think it's a huge population that's at risk of loneliness and isolation, especially I would say with the political kind of atmosphere right now, the lack of funding for that specific subgroup and also kind of the vitriol has caused people to feel more lonely and isolated as well. So we went about and designed this group intervention partially based on resources, but also because we felt that needing to follow up with people was probably going to be more helpful in a long-term basis in helping them learn some of the skills around interacting with other people and practicing that in groups. So our model is this kind of hybrid individual group social prescribing model. So I think it's social prescribing. And I think it's a variant of social prescribing. So what we're doing is having two individual meetings at the beginning where we're overviewing with individuals what social prescribing looks like, and then doing individualized planning and resource overviews and helping people connect to any resources they may want. So and then we have a series of group meetings after that. So in group, they're doing a exercise, kind of mapping their current connections and mapping what their desired connections might be. And then we're going back again to an individual meeting where they're doing kind of SMART goals or like specific measurable. I don't remember what the AOR is. Time bound goals for in a connection plan and creating and being accountable for that for the next 6 weeks after that. And then basically people are checking in the group once a week after that to look at a bunch of things that could be barriers to connecting and learning skills that are social skills so that they can better connect in the network. And then like we're also bringing in examples of activities that people can engage in that are social activities where they can meet other people. So that could be a music group, that could be a knitting group, that could be a volunteer group. So we're introducing people to different things as kind of that activity, and then at the end, sustaining a plan with that. So we're kind of combining social prescribing with a group medical visit in some sense, and seeing if that has um, good impact for patients with loneliness and isolation. So other items of note, we actually tried to do these in person and no one showed up. So we went to Zoom. And interestingly, at the end of the Zoom, at the end of the 8 weeks, people were like, why didn't you do these in person? We would have loved to meet other people in person. But we were like, well, no one came when it was in person. So that's why we did them on Zoom. So it's kind of this dichotomy where people, especially young adults, I think, were a bit afraid to show up in person, and that was a huge barrier for them rather than just signing in at home on their computer. But then they desired that in-person interaction, I think, towards the end. We also set them up with a asynchronous connection tool that they could connect with each other. So it's also the group becomes not just a way for accountability and social skills development to then reach out to things in the community and the resources in the community, but it also becomes a network and bonding group experience for them as well. And of note, we this was facilitated by a social worker. We also had a master's in social work student facilitate a few groups, and we found that that was effective. We are looking to see if we can expand to having like lay individuals do some of this work, but I think then there becomes a billing issue if we have lay people. So I think sticking with a community health worker or a social worker, I think is our preferred kind of approach to this. I'll just spend a few minutes talking about some of our evaluation results, some of the preliminary evaluation, then hopefully open this up for broader discussion as well. So we did two studies that we've completed so far. One was with young adults, as I kind of mentioned, and one was with people on chronic opioids who were at risk of opioid use disorder. So with the young adults, we recruited them through a EHR based cohort, ages 18 to 25, and we basically surveyed people who had been seen in their primary care clinic within the past year to see if they were had any loneliness, and kind of did this population health approach to it through and we reached out to them with my chart messages. Um, and then screened them with the UCLA loneliness scale, got demographic information, and then they were assigned to either CBT or social prescribing. And this time it was a 5 week intervention, and then got kind of outcomes from them and semi-structured interviews to talk about the experience as well. What we found, especially with the young adults, was that This was a really high risk group. The PHQ-9 was on the outcomes for our study, and 40% of people scored something other than zero on the ninth question, which actually asks about suicidal thoughts and ideation. Um, and we realized there was like a huge overlap between kind of like lack of belonging and perceived burdensomeness and capacity for suicide. So that became something we kind of talked about a bit as well within the group unintentionally, because like, well, like we need to address suicidality before we talk about connection as well. And like it's kind of cyclical, but I think both of those things were related as well. Just to look at the social percent was misspelled as SN. So the SN groups, we did see decrease in UCLA score in anxiety and in depression. The CBT groups, we found the same as well. But people actually attended and liked the social prescribing groups more than doing CBT. I think people didn't like the idea of like therapy. So I think the social prescribing groups kind of won out. And then in the chronic pain study that we did with people with opioid at risk for opioid use disorder, we had patients referred from 16 primary care clinics and two health systems in the Seattle region. And they got randomized to either 6 weeks of CBT or 8 weeks of social prescribing or to usual care. And we did these virtually as well. And this is preliminary, but what we're seeing is that the social prescribing group, the loneliness goes down substantially compared to usual care and is trending towards significance. Our p-value is 0.07. We don't have the full results yet. And then we saw decreases in depression, anxiety, and also opioid misuse as well. So I think our next steps is kind of growing this out into a sustainable model beyond our study. We're talking with our health system to see if this is something we want to bring on a longer term basis and develop some sort of regional referrals model as well. We're talking with our integrative care group to see if this is something that we can sustain long term. And then I think I'd like to see how we build this into a general primary care study that could be funded in the future. In the short term, we have some funding we're doing with cancer survivors right now because that's someone just handed us money for that. So I'm like, sure, we'll do it for cancer survivors. And then we're looking to see if we can do this with a broader group of young adults and then people at risk for suicide specifically, since that seems to be a group that popped out to us. And then my goal is really to help keep on developing the evidence for social prescribing so that we can really move this forward and sell this as well. So um, I'm happy to answer any questions, and I'm also happy to talk to anyone by email afterwards as well. So that's what I have. Have I stopped sharing? Sorry. Oop, here
Wonderful.
we
Thank
go.
you so
Okay.
much. Now, yes, now the share has stopped. Thank you so
Okay.
much. I have many questions, but I want to make sure and give others the opportunity. Since we do have several new faces tonight, or new names, I should say, I don't see many faces. As people ask questions, I invite you just to quickly introduce yourself to the group as you ask your question, because I think we have several new folks on tonight. So just want to open the floor to questions to anyone before I start to ask a couple that are on my mind. Okay, well, I'll get it rolling. Um, my first question, I'm an occupational therapist by background, so uh, one of my first questions that comes to mind is, do you envision having OT involved in this structure at all? I understand you have social worker and you're considering maybe having a layperson. Have you thought about OT as a billable option? And very aligned with this field, definitely.
I think that would be amazing to have OT involved.
Mhm.
I think I used a social worker because there was someone who had available time on my team. Like that, I'm going to be
Hmm.
honest about like why we chose a social worker, right? And who was like excited about this type of work and had available time. I think this could be occupational therapy. I think this could be a community health worker. Like, I think this is kind of like a thing I feel like could be very interdisciplinary in nature and could be led by a bunch of different people. And each person I think would bring different lens and expertise to something like this.
Hmm. Definitely. Yes. Any other questions from the audience? I'll ask another one while people's maybe wheels are still turning. And some of our members in the audience might be just kind of taking it in, Dr. Tong, and new to this concept, right? And so we definitely have a mix of people that are more familiar with social prescribing and those that are coming just to learn more. Um, After the group ends, is there any type of like kind of, are they leading into in-person interactions? You mentioned sometimes they wish they had that opportunity, or what is kind of like the transition phase after the group ends?
Yeah, I think unfortunately it was like they were research study based. When the group
Hmm.
ends, the group kind of ends. I think we set up a the social media app we use was Discord. We let them continue to interact on Discord and make plans to meet up. We told them it was going to not be monitored by anyone in the research team, but like were able to continue to do that. And I think we encouraged people to contact each other and continue to stay in contact. Some people did. I think the focus of our last group session was very much like, here are the community connections we've talked about. Here are the ways we've connected you to community resources. How can you sustain that and keep things going beyond
Hmm.
what we're doing in this group? So I think that was kind of our goal, was not that this would become like, because I've seen other interventions where like it keeps on going, right? Like it's kind of like
Hmm.
almost like long-term therapy in group setting, and that was not the intent. And I think it would have been a hard sell eventually to our health system to have that type of model. So I think we very much want to have a time limited model that people then could sustain their work afterwards. And I'll add one thing that, like, when we looked at outcomes, we actually saw that after the group ended, like our group ended at 8 weeks, and at 16 weeks, when we measured outcomes again, people's loneliness continued to decrease. So that was actually a
Hmm.
really surprising finding. It was usually like after the intervention ends, we're like, oh, people's loneliness might get a bit worse, but like we actually saw it like continue to get a decrease in nature.
That's wonderful. Because it sounds like the group was really almost like a pre-social prescribing, like skill building. And technically with a social worker there, it's kind of like not completely non-clinical, right? But
Yeah,
getting people ready to maybe participate in a community group and helping them build the skills to take part, which I think is a really crucial piece, especially for people with higher risks or kind of more clinical needs. I think it's a really wonderful model.
thank you.
There's a
I see
question from
con. Oh,
the
yeah.
text. Yes. Oh, I was just going to say, what was from Connie? What was the age demographics involved, and how does this impact obtaining engagement to address their loneliness?
Yes. I the first study with the young adults was 18 to 25. The chronic pain group, technically it ranged from like 18 to like as old as you might live, right? In reality, I think our median, if I don't quote me on this, I think our median age was like around in the 50s, and people mostly range from the 40s to 60s. What we found with that group was we didn't cohort by age, and when we had some people in their 20s join, they were like, I don't relate to what the 60-year-old is talking about, right? So I think we need to do better age cohorting if we want to do groups with this in the future. And then I think people in this 60s or 70s were like, I don't relate to what this 22-year-old is talking about either. So it goes both ways, I think.
And I was wondering,
Yeah.
knowing what you know now, what would you have done differently with these groups?
Yeah, I think age cohorting is definitely one thing. I think one thing we could do is, especially trying to build social skills with people, I think maybe actually having the first few groups virtual, and then maybe, not that we would do a bait and switch, but I think we would get like kind of group consensus to maybe meet in person and potentially in community settings where they can actually like visit local resources where they can find things, right? So like I think that could be something that I think we will explore in the future. I think if we're looking at how to build that in a clinical setting, that becomes harder when you're like, oh, well, visiting this like I don't know this like volunteer organization or this knitting group in the community. I don't think you can bill for that, right? But you can, I think, in a virtual setting. Um, I think the second part of Connie's question is how does this impact obtaining engagement? Um, I will say for the older populations, often we were teaching them how to use Zoom for some individuals. So that was definitely harder. And then how we got referrals was different as well. Like I think with older populations, we got them directly from clinicians. We got the younger group mostly through my chart patient portal messages. I will add that when we talked about this as a loneliness as social prescribing with a loneliness intervention, there was actually a lot of resistance to it initially. I don't know if other people have that experience. So we eventually were talking about it as like we did the opposite, right? Like I think we talked about it as like a connection and wellness intervention. People don't it seemed to not like hearing that they were being cohorted as a lonely group, I think. So it was interesting. That was a lesson that I learned as well. How to advertise this and how to talk about the referrals. Kate?
Oh, hi, can you hear me? Okay. I was just wondering if you had considered doing any sort of work because you were talking about the link worker, community health worker with like remote health and wellness coaches or anything, because there's a lot of skill building. You're talking about the SMART goals that goes into that sort of work. And then there's also different people that could work remotely or be kind of like a bridge friend to help people. Um, kind of ease their way into community if they're nervous to meet in person. Is that something that you guys have considered? And I guess they have some billable relationships also with
Yeah,
companies.
I think that's a great idea. We can incorporate that into the next project we do, I think, to like have kind of health coaches and some other people who have expertise in those areas, I think, because I think it's definitely looking at a team approach and looking at the resources that are out there already can be really helpful.
The health and wellness coaching through open source wellness, the community is medicine model is something that I've trained in, and that's really helpful to get people just more excited about their community and feel like they fit in. So it just seems like it resonates.
And Kate, do you want to go ahead and just briefly introduce yourself to the
Oh,
room? We want this to just be interactive and,
uh,
not so much a webinar format, but,
uh,
here to interact with each other and help each other brainstorm how to get social prescribing into your places of work or kind of help people move forward.
Sure, that's why I popped off because we're all hiding. It just, when you're talking about people being afraid to even meet in person, that's what it made me think of a little bit. And we're social prescribing advocates. But I'm Kate, I'm in Cleveland, Ohio. I do health and wellness coaching and dance movement classes, both in person and remotely. And I'm at school at University of Florida as well for arts and medicine.
That's great. I think like finding common activities for people to on is definitely a way for people to meet and work together, right? Like I think like finding common hobbies. So I really like your ideas and kind of your lane of work as well.
One last thing is a lot of companies are paying billable for health and wellness coaches, so that's helpful, I guess, kind of immersion. But
And I think this model reminds me of the community as medicine model because we had Liz Markle come present. I believe that was, wow, I think that was February. I can't believe it's been 10 months already, but I believe it was February. And they also use a group medical billing model It's in person, not virtual, but yeah, it also came to my mind as a kind of a similar model.
I think they have some virtual cohorts as well then.
Okay. Oh,
Hmm.
wonderful.
Yeah, they
Yeah,
do
Yeah.
it both
yeah.
ways.
Hmm.
Yeah.
Hmm.
I
Wonderful.
think that's what you were trained in, right, Kate? The
Yeah.
community medicine. Yeah. Okay.
Hmm.
Yeah, it might be worthwhile to connect with them. Sebastian.
For sure.
Pam, did you have something you wanted to jump in and share? Yeah. And
Yes.
if you want to just briefly intro yourself. Uh,
I'm Pam Wilson. I'm located down in Babcock Ranch, Florida. I'm a nurse by background. Very, very interested in the social prescribing. So I'm kind of taking a transition with my nursing career a bit. So I've been trying to dig and learn quite a bit. And one thing to think about is as as the program evolves, is really looking at the Medicare Advantage type plans for with the elderly, because my understanding, there are some aspects of it that they do cover some type of programs that may assist patients that do have problems as far as with loneliness and just need, like that connectiveness and everything too, because as we know, that leads to even more significant health care problems with the elderly as well too. And like you mentioned, Sebastian, it's really kind of like this whole different age cohort to look at as well too. But it's definitely a big area as well to take a look at and kind of see how the over time. But most of the billing is private for a lot of these type programs for the aging population, but some of the advantage plans and do I think open it up a little bit.
I think there's definitely potential for Medicare Advantage to be working on this. I don't know anyone who works for a Medicare Advantage plan, but I think if someone did, that would be great to see
Yeah.
if like this is something that Medicare Advantage could
Hmm.
cover. And I think we all know kind of the problem with older adults and looking at especially
Yeah,
people with like multiple comorbidities, how much lack of social connection really affects them. So I think that could be a huge thing.
exactly. Thank you.
Yeah, I think we need to bring more. Yeah, we definitely need to do more proof
Yeah.
for Medicare to be
Hmm.
able to pay for this. So
I
it's
know
good.
it's more the advantage plans too, I think, versus the Medicare seems like. But yeah, as we get more info and if I discover stuff, I'll share.
Hi, everyone. My name is Sejal Desai. I'm a obesity medicine physician in Houston, and this is my first time on. First time, I listened to the webinar because I heard about the webinar and I found out what social prescribing was, and very interested. I see patients for weight management, so this is very much up my alley, and I think very important for so many people for so many reasons. So I'm just, taking all this in and trying to, figure all this out. But my question is how do I find, places to get involved myself or help my patients, get involved in something like this? Where, as a small doctor in Houston, where do I, begin, or where do I get more resources to get patients engaged in something like this? Thank you.
I don't know, Ivory or Alan, you want to?
Yeah, yeah, I was just going to jump in. So I think it's about the first step really is about knowing your community and serving the community and what is happening that has a low barrier to entry for people. So are there free movement groups? Are there movement in the park? Are there things where people can get involved without much barriers, which is something I want to ask Dr. Tong about as we move on. But really knowing what are the resources in your community and kind of building that list and database first so that you have an idea when you're talking to patients, like what's even available for them, and asking them their barriers, like what keeps you from being active? Is it kind of starting to have those conversations and seeing there's so many things that could be barriers, beyond just motivation. That would be where I would start. And finding, like Dr. Tong said, there happened to be a social worker that was passionate about this. And so finding those partners in your area that are passionate about this and maybe would be able to help with kind of that linking role, that link worker or community connector role. But I think really finding out barriers and finding out what's in your community, I would say would be first steps. Um,
We're interested in supporting that, and kind of part of what we're looking at developing inside of Kaiser is sort of helping people like figure that out for their community, or figure out an AI algorithm or some way to be able to do that easily, because we don't really want that to be a barrier. But I think that you can think about, I mean, I was just speaking with a dance organization that works with youth today, and like you can have one or two organizations, or like this doesn't have to be 10 or 20 organizations that you're referring to. I think you can really start in small ways, and it's still starting, and I still think it's powerful. Obviously, we want to work towards having. I'm a strong believer, as is Ivory, in the link worker model, and being able to really individualize what people, um, what do they need and what really helps feed them. But I think that we're really trying to look at changing how we practice, and I think doing it in small ways is probably a more realistic way that we're going to be able to just have more people starting to do it, and really push this agenda harder, while we try to work with healthcare systems to be able to change and find resources to be able to play that link worker role and all that. So it'd be great to just kind of find one or two organizations that are in your community and start.
That's the key. Okay, thank you so much. I've worked a lot with like Walk with a Dog because there's lots of those going on. So I've spoken at a lot of them, and but it's hard to get the community to come out. Like Dr. Tom was saying earlier, that even when they asked for in person, no one came, and then they did virtual, and so many people showed up, and then they realized that no, we really do need to be in person. So they need it, they want it, they're craving it, but it's hard to get them to come out. So, that.
I was just gonna say, I'm Stacy with the Human Canine Alliance, and one recommendation I would have is meetup.org. Every local area, type in your zip code, type in a keyword, you will find social prescribing groups happening, and they don't even know that they're social prescribing.
I think that's a great segue to the question of barriers. I work as a mental health OT in a supportive housing community. So about 1,500 people that were previously unhoused. A large majority are veterans, um, and a large majority have some sort of mental health condition. And I think the first thing is, what are the barriers? What is keeping people from going to meet up, right? Like um, are we serving people that just need like a tiny nudge? Or are we also thinking about people with comorbidities, people with severe and persistent mental illness? Are we thinking about people that need more support than just kind of a leaflet, or like a link? So I'd love to hear, Dr. Tong, from your perspective, what were some of the barriers that came up when that was explored in groups, if that's something that you took note of qualitatively?
Yeah, I think we definitely noticed that. And I think one of the reasons we did groups was that our sense was like, especially with subgroups that had higher risks and higher comorbidities, that they needed kind of the extra nudge beyond just a social prescribing, social prescription, or just like one or two meetings with a link worker. So social anxiety for young adults came up as a huge thing. And I think we worked with a lot of people who had done part of their college or high school virtually, right? Like we still had that cohort going through. So I think like some of the developmental milestones around how do you socialize with peers was missing in this group. So I think some of like I can't teach that in 6 weeks, but like what was missing a year of COVID, right? But or 2 years in some cases. But I think we can at least talk about those things openly. I think some of the barriers we noticed were just other social needs that were interfering, right? Like I think some people felt unsafe in their neighborhood. That wasn't something we could as easily deal with, or felt like they had other family responsibilities that took them away from being able to socialize. So I think some of the I think some of the skills to socialize can be learned. Some of the social barriers can't be. I think their accountability is a big thing. I think a lot of young adults kept on saying to us, I'm afraid how people are going to judge me. And we kept on saying, like, well, if you meet someone who's judging you and you don't like them, you don't have to see them again, right? Like, who cares if they judge you? But like that was a barrier that like we had to actually articulate and have them learn that insight. So I think it was important for us to see them again because I think otherwise we would give them something to connect to. They might go once and then feel uncomfortable going back, or even like getting to the first step. I think what was a challenge for some people as well.
I want to also congratulate you for working with this population. It's been a group that, you know, most stuff is happening with seniors, and you know, but yet the data supports the levels of loneliness that are happening in the age group you're working with. It's just such higher levels, 70% in some studies, and so it really is great to start knocking away at that. And how do we really work with this group that may not be as obvious as the first group to work with, but I'm really glad that you're doing that work. So thank you.
Any other questions or people that uh, just haven't introduced themselves and want to maybe share a relation to their work or their field? Dawn?
Yes. Hi.
Hi.
Dr. Tong, thanks so much for talking. And I just wanted to mention to comment on what Pam was talking about with older adults. A lot of the area agencies on aging that get funding through the Older Adults Act can fund evidence-based practice programs. And so as we get more research on this, I think that's an outlet to look at because they work with a lot of the Medicare Advantage programs, at least in Michigan, where I am, on those programs. And my background is as a recreational therapist, working mostly with older adults and people with disabilities. So I see a huge opportunity for social prescribing with the disability community as well.
I'll go. My name's Liz. Sorry, my camera's not on. I was in my son's room because he woke up. So anyways, I was also late, so I apologize. But I am a professor at Cleveland State in the occupational therapy department, and I'm also an occupational therapist by trade. And I mean, really, Ivory's the one who got me interested in all of this. So thank you, Ivory. My role, I guess, like right now, or my tiny contribution as of yet, is that I do have a capstone student that has been, he's a OTD student. So we got a contract going or an affiliation going with the Holden Arboretum, which is essentially like a big botanical garden arboretum collaboration in Cleveland area. And he's actually going to be doing his capstone starting in January there and doing like a full needs assessment, not just there, but also kind of looking at the needs of the Cleveland community and then also like what's available. Um, and that's kind of been my starting point. I will say it's taken almost a year just to get that going. So I do kind of feel sometimes one of my barriers to all this is I do feel like progress is slow, and just kind of trying to figure out how to work with that. And also just for me, like on the OT side, it's actually harder for me to like find physicians and ways to kind of integrate in that sense. Like we have a lot of like nature spaces and we have like an art museum and we have various things in the Cleveland community, but it's kind of finding like, again, it's like the connection piece of actually making it happen and finding funding and all of that. So for me now, it's nice that I have a student and I could continue to have students doing these things, but I guess that's kind of my stuff in a nutshell.
Liz, I
think,
would love to talk to you. I'm in Cleveland also.
Yeah, I heard you say that. So
Yeah.
like I took a note of your name.
Yeah.
I'll
Just
pop my stuff in, I'll pop my info in the chat for you.
I actually have a naturopathic medical student who's working with me, who is interested in nature-based interventions and is starting a pilot project on like how do we use nature-based interventions and social prescribing for that, and like forest bathing as a way to like find oneself in nature, but also like meet other people as well. So I think there's definitely a lot around that area that can be explored.
yeah, I also just think students are such a great way of like impacting the profession. They're passionate. They want to try something innovative. You know, they want to contribute something innovative to the field they're entering. And I think it's a wonderful way to move this, advance this in across all disciplines, you know, because this really is very interdisciplinary work. Um, Sherry, I see you joined us. Do you want to introduce yourself and any thoughts or insights about how this kind of relates to your line of work? You're on mute.
So I'm actually on the other side of the arena. What I do is I got into the hobby of doing sound healing. So it's using sound to help people relax. And at first I was doing with my friends, a bunch of hikers. We all have like issues in our life, but we just got together early in the morning, go hiking, we kind of chat, and then we share, and then we feel happy at the end, we go home. So that is kind of like a social prescribing, but we just do it on our own. And I didn't know about this until I started kind of getting serious about doing my sound healing. I started doing it at the park, and I was at first I wanted to promote my business, and then so I was like, I do it for free, for donation only, and then people start to show up, and then they start sharing their story with me, and then say, oh, it's like I'm looking forward to this. It's like I'm working from home, I'm feeling lonely. Now I can get out, and they don't have to do anything. They just come and they bring their mat, they lay on the floor, lay on the grass, and they don't have to talk if they don't want to. And eventually we start to have like they start to have like small chat, and then we start to build a little community. And then that's when I came across social prescribing when I was like scrolling my Instagram. So I thought, oh, it's something interesting, maybe something in the long run. That is something that we can help, because I do see a lot of people, they come, they say, I can't afford to pay more to do sound bath, so I'm coming to you. Or I have people who come on a regular basis who say, they'll tell me that once they have the sound bath, they feel more relaxed, and then they can kind of go home and just kind of deal with the stress. So I feel like I don't know what's gonna happen, but I feel like maybe there's a connection with what you guys do and what I do. Maybe eventually something will happen. I don't know. Yeah, that's why I'm here.
Wonderful. Thank you. Connie?
Can you hear me? Okay.
There's an echo on my end.
Oh, sorry, I'm just trying to get this.
I think it might be coming from Sherry's mic.
Is that better?
Yes, it's gone now.
Oh, okay. Hi, my name is Connie. I'm a lifestyle and occupational medicine physician. I recently attended the American College of Lifestyle Medicine conference, and there were several sessions about social prescribing, and one with Dr. Desai mentioned a walk with a doc, and U.S. Men's Shed, and I actually have appointments next week to talk to them. And I'm super interested in figuring out how I could, being a solo provider, start this in my community, but similar maybe to Dr. Tong in that while I want to help with the adults, I want to somehow use some of the revenue to start helping the young generation. because my kids are 13, 15, and I see them and they're, um, they're kind, and there's a lot of social anxiety, and especially with social media and digital age that they're in right now. I just feel there's more loneliness than ever, especially. So how can I use what I could do to help educate the young generation? So hopefully that they'll live with not just health, but well-being as well. So that's my journey right now.
That sounds great. Yeah. I mean, Dr. Sunderman, Melissa Sunderman is who's definitely speaking at, at the lifestyle medicine, is one of our advisors and one of the leads in nature prescribing for lifestyle medicine. And she'd be a good contact. There and Dr. Thomas, I think she was speaking as well. So anyway, they I think are very interested in helping to grow this. And I think that there's some relaxation in the fact that like it really is about social connection and probably matters a little bit less about what we figure out people are going to be doing. It just seems like, yeah, just lots of things that create social, there's a lot of ways to create social connection. So I think that, you know, that has given me some relaxation about it, that like we have to exactly
Right.
match people up to exactly what the right intervention is. But if, I love that, Sebastian, that you did groups, because honestly, just creating groups, and of course this is social prescribing, it's, not exactly the classic textbook model of it, but it is a form of social prescribing. I have done group medical visits for, whatever, over a decade. And I think that's a form of social prescribing. I think that there's just a lot of different ways. And, the magic happens when you get people together. Sometimes it hits for some people, sometimes it doesn't, but the social connection part really does. And in person, I don't know, I think is probably pretty important for some of that. So I think, yeah, so I know it's hard logistically, but I think it's worth the efforts if we can.
Yeah, absolutely. And I'm learning from this group, and I read that, just start somewhere. Just start somewhere, and just try to figure it out along the way, and just keep on pivoting until you hit those connections. It's worth it.
Absolutely. Well, thank you again so much, Dr. Tong, for sharing with us. I think it's such a wonderful model. I think it's very unique way to, like I said before, kind of give people that skill building and almost sounds like a bit didactic in parts of the group, and kind of setting them up for success as a phase of then maybe being able to transition into a non-clinical community-based group. So really loved hearing about your approach there. Um, we have just a few minutes left, so just want to kind of look forward. So we polled, this group has been running for about a year, and we did a 6-month check-in poll over the summer, and yeah, just kind of checked in with you all to find out um, what was the most beneficial in formatting and content for you all. And we found that people really liked having a guest speaker, and I know I always learn something from each guest speaker, and helps me be able to kind of connect the dots when other people ask something. It's like, oh, well, this worked in this setting, or this worked for this person. So I think it's very helpful. And then we also heard from you that you like to have kind of working sessions and strategic sessions and stuff. So on that note, Social Prescribing Day of 2026 was announced it's going to be the end of March this year, I believe March 26th of 2026. And so our next meeting, which would be, we always meet on the second Monday of the month at this same time. So our next meeting will be Monday, January 12th And so we are not going to have a guest speaker that month. We will be kind of starting to plan and think about what we can do individually or collaboratively for Social Prescribing Day in different settings. And so that's something we did last year, and we gave some ideas, and people, got involved in different ways. And so I really hope that you all can join us again in January to start thinking, planning for the future. And then we'll probably continue roughly this kind of every other month as a guest speaker. Every other month is kind of more a setup where you all will have time to talk and get to know each other's background and help each other problem solve and things like that. So we hope you all join us.
Sounds good. Thank you for coordinating.
Thank you so
This.
much.
Good.
Yeah, this is wonderful. Thank you.
No,
Thank you.
thank you very much.
Thank you all. Thank you, Dr. Tong.
Yes, thank you very much, Dr. Tong.